I request the attention of all the respected faculties and delegates. Kindly allow me a few minutes of yours and let me introduce myself and the faculty members of this session. A very good evening and a warm welcome to one and all. I am Rituparna from ClearNet, the designated session assistant for a seamless experience. And ClearNet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. ClearNet is very proud to be a digital partner for the webinar on advanced hemodynamic monitoring and TEE in oncoanesthesia organized by the Society of Oncoanesthesia and Perioperative Care. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Rakesh Garg, the Honorable Chairperson for today. Welcome you, sir. So the dice is all yours. Please proceed.
Thank you, Dr. Rituparna. And continuing with the Society of Oncoanesthesia and Peri-Operative webinar, in this series, today we have another yet very important session for the various major surgical procedures in the cancer aspect. And today's topic is the advanced hemodynamic monitoring and the use of transesophageal echocardiography in the perioperative care for patients undergoing oncosurgical procedures. And we have one of the best speakers among us to take this important topic forward. And she is none other than Dr. Shagun Bhatia Shah. Yeah. So I think everybody of you is aware of Dr. Shagun because of her extensive work in oncoanesthesiology, perioperative care, and oncocritical care. She has many laurels to her for contribution in the academics and research. I personally know her. She had wonderful many articles related to cancer surgical procedures. She has published various articles which has bring her accolades of the best original articles, the Young Researcher Awards, the best oral paper, best poster, and many and so forth things. She is on a prestigious post of international committee member at IEARS, which is one of the big society from USA. She also is member of the various societies. She is well-renowned speaker, faculty, chairperson, judge to many of the national and international conferences. Huge number of publications. So without wasting time, I will request Dr. Shagun to take us forward on this important session of hemodynamic monitoring and transesophageal echocardiography for cancer patients. Over to you.
Thank you, sir, for your very kind words. I'm overwhelmed, literally. You yourself are a stalwart in the field of oncoanesthesia. No, everybody knows you, sir. So I'll just start to share my screen with no further ado. Okay, so my dear fellow anesthesiologists, a very good evening to you. And the topic of my presentation today is advanced hemodynamic monitoring and transesophageal echocardiography in oncoanesthesia. Right. So today we'll begin with why advanced hemodynamic monitoring is important for oncoanesthesia patients. It's not just fluid management. You know, it goes beyond fluid management because there are comorbid patients with cardiac patients with the low left ventricular ejection fraction, patients with arrhythmias, patients with chronic kidney disease, pulmonary edema, critically ill patients, hemorrhages, and you know, all these patients also require advanced hemodynamic monitoring besides, of course, the major and prolonged surgeries like CRS HIPEC, ovarian lap, Whipple's, liver resection, so on and so forth. Right. Okay. So now I'll give you an overview of what to expect today. So today we'll discuss the various tools and techniques available to us for advanced hemodynamic monitoring, and then we'll discuss how to use these tools which are available to us. Right. So we'll discuss advanced hemodynamic monitoring under the invasive monitors, the semi-invasive monitors like LITCO and PICO, the minimally invasive ones like the esophageal Doppler and transesophageal echocardiography, and the non-invasive ones based on volume clamp and TTE and Nikon, Icon, and all that. Okay, so goal-directed fluid therapy is all about getting the fluid balance right. On both ends of the spectrum, you have an adverse outcome, because if your patient is hypoperfused, you may end up with acute kidney injury, sepsis, and multiple organ dysfunction. And on the other hand, if your patient is hyperperfused and there's hypervolemia, you may get edema and pulmonary dysfunction. So it's really, really important to individualize the hemodynamic targets and offer tailor-made fluid therapy for these patients. And this is made possible by advanced hemodynamic monitoring. And there's a vast array of monitors available to us, as we shall see subsequently. So what is important is a basic knowledge about the hemodynamic pyramid, because adequate organ perfusion is the primary goal of hemodynamic monitoring. And organ perfusion in turn depends upon two major factors: the blood pressure of your patient and the regional vascular resistance. Now, blood pressure is a product of cardiac output and systemic vascular resistance. And systemic vascular resistance in turn depends on, it's inversely proportional to fourth power of the vascular radius, and it's directly proportional to 8 times the length of the vessel and to the blood viscosity. Cardiac output in turn is a product of stroke volume and the heart rate of your patient. And stroke volume in turn depends upon 3 pillars: preload, contractility, and afterload. And each of these can be individually monitored using advanced hemodynamic monitoring, as we shall see subsequently. So firstly, CVP was available to us, and we could measure the central venous pressure with it and infuse medications and even allow for dialysis after certain modifications. But a CVP line can result in multiple complications like infection, thrombosis, complications on insertion, and it does not reflect the actual right atrial pressure in most situations. And above all, it's not a dynamic parameter. Then came the arterial line, which gave you the systolic, diastolic, and mean arterial pressure, the pulse pressure variation. You can draw ABG samples from it, and it gives you a beat-to-beat waveform. And from this waveform, you can calculate cardiac output by calculating the area under the curve. But then why should you indulge in so many complex calculations when a hemodynamic monitor can offer you all these and leave you free to attend to your patient in other ways, like giving medication and so many other things at the head end, right? And moreover, an arterial line is invasive. There's a risk of hematoma formation, distal ischemia, gangrene formation, even after doing an Allen's test in most instances. So the gold standard nowadays is still the pulmonary artery catheter, which is inserted through a sheath inserted in the internal jugular vein. It gives us a lot many parameters like pulmonary artery pressure, the CVP, the right ventricular end diastolic pressure, the pulmonary artery wedge pressure, the cardiac output, cardiac index, stroke volume resistance index, systemic vascular resistance, pulmonary vascular resistance, and then these, and also it's a surrogate for PAO, pulmonary artery occlusion pressure, right? So despite that, despite being the gold standard, it's still not much in vogue because it's costly, it's invasive, and it can result in multiple complications like arrhythmias on insertion and catheter looping, balloon rupture, etc. And most importantly, there are several meta-analyses in which no mortality benefit has been observed by using a pulmonary artery catheter, which means that by using this catheter in patients where it's not used and in the subset of patients where it has been used, the post-op mortality is the same. So people argue, why use it? Okay, so next hemodynamic monitor which came along is the PICO, or the Pulse Index Continuous Cardiac Output Monitor, based on the principle of transcardiopulmonary thermodilution and pulse contour analysis. It gives you a host of parameters like mean arterial pressure, CVP, continuous cardiac output, cardiac index, stroke volume variation, pulse pressure variation, global end diastolic volume, which is a measure of preload, systemic vascular resistance, which is a measure of afterload, extravascular lung water, which gives you the amount of pulmonary edema, then cardiac function index, which tells you about the contractility of the heart. So many things it offers you. But a standard CVP line is required for transpulmonary thermodilution. So it requires both an arterial line as well as a CVP line, but it's unable to measure the pulmonary artery pressure, unlike a pulmonary artery catheter. And of course, it has the limitations associated with pulse contour analysis. And also, pulse contour analysis is dependent on the site of the arterial line cannulated. So if you want the maximum fidelity, you should use the femoral artery for PICO. So this is how transpulmonary thermodilution works. You inject cold saline into the vein to obtain the pulmonary thermal volume and the intrathoracic thermal volume, the difference of which will give you the global end diastolic volume. And if you multiply the global end diastolic volume with 1.25, you get the intrathoracic blood volume, which when subtracted from the intrathoracic thermal volume will give you the extravascular lung water. Now, by the Stewart-Hamilton equation, you can obtain cardiac output using this transpulmonary thermodilution technique, because you know the temperature of the blood and you know the temperature of the injectate and also the volume of the injectate, right? So you can obtain cardiac output like this. And the other method by which you can obtain cardiac output is by pulse contour analysis. So here you multiply a calibration factor with the heart rate with an integral of area under the pressure curve and add it to the product of aortic compliance and shape of the pressure curve given by dP by dt. Now, PCA is unreliable in many patients, like those with pulmonary, those with arrhythmias, atrial fibrillation, mechanical circulatory assist devices in situ, those with aortic valve pathology, and of course, when your arterial line is either kinked or damped, right? So with this knowledge, we know that there's another monitor called LIDCO. Now, LIDCO is transthoracic lithium dilution instead of thermodilution, and it also uses pulse contour analysis. It gives the same parameters as PICO, and no CVP line is required for this. But then again, there are certain drawbacks that it's unreliable in patients on chronic lithium use, like patients with MDP mania. And it's useless in patients, unreliable in patients on benzyl isoquinoline neuromuscular blocking agents. And all of us use atracurium in most of our patients. So LIDCO becomes slightly shaky there. Then calibration is required, and it requires input of hematocrit as well as serum sodium values. And of course, LIDCO is unable to measure the pulmonary artery pressure as well as the extravascular lung water. Okay, so next in line is the first generation cardiac output monitor or Vigilio. And this is based on the principle of pulse contour analysis, gives you the continuous cardiac output, the stroke volume variation, systemic vascular resistance. But unfortunately, an arterial line is required for a reliable trace, and it has all the limitations of pulse contour analysis, like when arrhythmias are there, cannot be used. Moreover, it's got a very poor accuracy, just 58.8%, the 58.8% error versus pulmonary artery catheter, especially when the patient is hemodynamically unstable. That's when you want it the most, and it's not giving you the right reading at that particular time. Plus, the disposable sensor is very costly. So the second generation hemodynamic monitor was produced, and this is the EV1000 or the VoluView, based on the principles of pulse contour analysis and transcardiopulmonary thermodilution, which we've already discussed. It gives you all the parameters which LIDCO and PICO give you, along with an animated physiology screen, a cockpit screen, and a goal positioning screen, which allows you to monitor and track the relationship of two key parameters by plotting them against each other on an XOY plane. Then the latest one in the line is the Hemosphere, which is used along with an Acumen IQ cuff or sensor, and it gives you the novel new parameter called the hypotension prediction parameter. So hypotension prediction index, or HPI, ranges from 0 to 100. Higher your HPI, higher the likelihood of a hypotensive event, which is defined as mean arterial pressure less than 65 millimeters of mercury for more than a minute. HPI is updated every 20 seconds. And whenever it exceeds 85, there's an auditory alarm. So just to give you an example, if your HPI value is between 90 to 94, it means that there's a 95% probability that in 95% of your patients, within the next 3.6 minutes, you will have an episode of hypotension. Or in other words, you have 3.5, 3.6 minutes with you in which you can give medication and take measures to avoid or prevent this hypotension episode. And like we know, BP control is the basis of organ perfusion maintenance, right? Okay, so we shall also discuss certain other parameters like fluid responsiveness. So functional or dynamic parameters like systolic pressure variation, pulse pressure variation, and stroke volume variation are the most sensitive in mechanically ventilated patients. Whereas there are other parameters like passive leg raise and lung recruitment maneuvers, tidal volume challenge, mini fluid challenge, which are difficult to perform in anesthetized patients. Then there's another parameter called EA-dyne, or the dynamic elastance, which is the ratio of PPV and stroke volume variation. And it's a measure of pressure responsiveness. It's also a measure of afterload to the left ventricle by the arterial system relative to the left ventricular elastance. The next parameter under consideration would be the systolic slope, or dP by dt. Now, this is the maximum upslope of the arterial pressure waveform of a peripheral artery. The trend in the values of dP by dt are more important because they indicate increasing or decreasing cardiac contractility. So I'll now discuss a new monitor called MostCare. This is important because this particular monitor gives you all the values which Hemosphere and EV1000 give you, except of course for the HPI. And most importantly, no consumables are used. Sensors are not required. So you invest in the instrument once and you do not repeatedly have to invest in the consumables. It's based on the PRAM, or pressure recording analytical method of pressure wave analysis. So the discussion would not be complete without a mention of Capstesia, or the smartphone-based hemodynamic monitor. This gives you all the values like cardiac output, cardiac index, pulse pressure variation, dP by dt, systemic vascular resistance, and all this just for 500 rupees a month. So in 5 euros a month, you can take as many readings in as many patients as you like, right? So Capstesia app requires just a snapshot of the arterial waveform obtained from either an invasive arterial line or from a non-invasive finger probe. It does not require any external calibration. But you should have a high-speed internet with you, which most of us have nowadays, 5G and all that. And you should be careful that while clicking a snapshot of the screen, of the monitor screen, you should keep your mobile or smartphone screen parallel to the monitor screen to avoid any parallax error. Okay, so now we come to non-invasive hemodynamic monitoring, where I shall mention ICON, which is based on bioimpedance. It gives you all the parameters which the semi-invasive monitors give you, and you just have to attach electrodes at 4 places on the body. Right. So there's another monitor called NECOM, which is based on bioreactance, and 4 double electrode stickers are placed on the thorax, and high frequency current is passed between the 2 outer electrodes, resulting voltages are recorded between the 2 inner electrodes, and a relative phase shift and rate of change of phase between these signals is determined, from which we calculate the cardiac output or the cardiac index. All right, so this is NECOM, but then it has certain drawbacks. that it's accurate only in mechanically ventilated patients, and multiple potential errors can occur in respiratory disease patients. Plus, there's limited data on its accuracy versus the pulmonary artery catheter. So here you can see that there is this graph showing aortic flow as a function of time. And you can see that the peak flow or the maximum flow in the aorta is proportional to the rate of change of impedance, which is useful in the bioimpedance technique. And it's also proportional to the rate of change of phase, which is the basis of bioreactance technique. So we can calculate stroke volume from all this. Let me elaborate it a bit further for you people. Now, stroke volume is calculated by multiplying a constant with the ventricular ejection time with the rate of change of phase. So, bioreactance techniques are more robust and less susceptible to noise than bioimpedance techniques, just like an AM and FM radio. Okay, so now we come to esophageal Doppler monitoring, and you have the cardio-Q monitor, which is slipped inside the esophagus of the patient, and it determines cardiac function parameters in real time based upon measurement of the aortic blood flow. No arterial line is required for it, and no CVP line is required for it. Okay, but then there may be trauma during esophageal probe insertion, and it's contraindicated in esophageal pathology, esophageal cancer, webs, etc., just like the TEE probe is contraindicated in these patients. And it makes assumptions about descending aortic flow as a proportion of the total cardiac output. Plus, the window is really small and it requires frequent repositioning due to this. Okay, so an eyeball view or qualitative echocardiography is also important, and we shall come to this when we discuss the transesophageal echocardiography. Okay, so a word on the ClearSight. Now, ClearSight obtains continuous cardiac output from pulse contour analysis of non-invasive blood pressure waveform by the volume clamp method. So this volume clamp is applied on the finger of the patient, and continuous measurements of finger BP by using a finger cuff comprising an inflatable bladder and a plethysmograph is done, which incorporates an LED source and a detector. The light is absorbed by the blood, and the pulsation of the arterial diameter during a heartbeat causes a pulsation in the light detector signal. So you also have PhysioCal, and this should be more than 30 beats if ClearSight values are to be relied upon. This is akin to the signal quality index in your BIS monitor. Okay, but then again, it has certain drawbacks like its prohibitive cost, especially each consumable costs very dearly to the patient, 28,000 per ClearSight finger probe. Then manufacturer guidelines have to be adhered to, and PhysioCal values have to be more than 30. And it's not useful for patients undergoing hand surgery or patients with hypothermia or vasoconstrictors in use, and where there's no peripheral perfusion in the finger, as is obvious in the site of probe application. So now a mention of the CNAP. Now, CNAP is just similar to the ClearSight, except that it has no consumables to be used, and it uses a double finger sensor. So once it uses the sensor one finger, it gets inflated, then the bladder on the other finger gets inflated. After every 15 minutes, the finger is changed by itself automatically. It gives you all the parameters which ClearSight gives you, like continuous blood pressure, cardiac output, cardiac index, stroke volume, systemic vascular resistance, pulse pressure variation, and stroke volume variation. Now we come to the pleth variability index. Now this is a continuous, non-invasive dynamic index ranging from 0 to 100. And this is a measure of fluid responsiveness in mechanically ventilated patients. And the beauty of it is that by using a single pulse oximeter probe, you can get it. You can get the values because it reads the SpO2 waveform instead of the arterial pressure waveform. So you don't need an arterial line or a CVP line. You can just put a clamp on the finger and you can get the values. Okay, so now let's monitor the trends and guidelines. We were earlier told that urine output is the best guide for hemodynamic monitoring. But now we know the diuresis reflects the blood pressure, the fluid intake, the stress response, hormonal changes. So of course, urine output is an unreliable guide. We were then told that CVP is the best guide. But then now we know better. We know that CVP between 5 and 20 millimeters of mercury has almost no predictive value. So again, it's a useless guide. Then we were told that pulmonary artery catheter is the gold standard. Of course, that's very much true even today, but it's clinically too invasive for routine use. Then we were told that serum lactate is a good guide. But now serum lactate is of course good, but it's not a dynamic indicator and it requires an ABG sample to be drawn each time to get the value. Transesophageal echocardiography is good. So is esophageal Doppler, which was used by the FEDORA trial. But now we know that the FEDORA trial is of questionable quality. Finally, we know that several ERAS protocols have utilized goal-directed fluid therapy using pleth variability index, delta stroke volume, PPV, and stroke volume variation as goals. And the INPRESS trial too has used these parameters as goals for individualized fluid therapy. But again, there's a gray zone here. PPV between 9 to 13, fluid responsiveness is not reliably predicted in 25% of the patients under general anesthesia. So HPI is a new variable on the horizon, and there are still studies which are going on to prove its effectiveness and validate it. So now for the clinical decision-making part. Out of so many tools, a cafeteria choice of hemodynamic monitors available to me, which one should I use for my patient? So this decision should be based on three main factors. Firstly, the invasiveness of the monitor. Since a pulmonary artery catheter is too invasive, in most of the cases, it's out. So we are left with semi-invasive monitors like the Pico, Litco, Vigilio, EV1000, Hemosphere, MostCare, and Capstesia. And also the non-invasive monitors like NECOM, ICON, CardioQ, transesophageal echocardiography, the CNAP, and the ClearSight, all of which are non-invasive. So to choose between semi and non-invasive ones, we consider the accuracy. So like we can see here, the accuracy of the semi-invasive monitors is slightly higher than that of non-invasive monitors like ICON or CardioQ. But then there are other non-invasive monitors like ClearSight and Capstesia, and for that matter, transesophageal echocardiography, which have the same accuracy as Litco, Pico, FlowTrack, right? So the third parameter which we can consider here is the cost effectiveness. So like we can see, the semi-invasive monitors are almost as costly or marginally less costly than the non-invasive cardiac output monitors. So for 30 lakhs, you can get a Pico or a Litco. For 36 lakhs, you can get a Hemosphere. But with a Hemosphere, you have to pay 24,600 for the FlowTrack sensor to be used each time in each patient. Then there is the other monitor, MostCare, where the initial cost is 3 lakhs higher than Hemosphere, but then you don't require any sensors or consumables. And of course, like I've already mentioned, there is Capstesia, just 500 rupees per month, and no consumables required except for a high-speed internet. Then we come to the non-invasive monitors. Here we can compare CNAP with ClearSight. CNAP, ClearSight will cost you 35 to 60 lakhs, plus 28,000 rupees per as a consumable per patient. Whereas CNAP just requires a rupees 10 lakh pod, which can be attached to your Draeger workstation, and it does not require any consumables. Then you also have the transesophageal echocardiography, and here you use 35 lakhs for the monitor plus 10 lakh for the TEE probe. But then no further cost, no cost of consumables except for the annual maintenance charges like in all the other monitors. So we can see that the choice is between using a petrol car versus an electric car, right? So either the initial investment is high and later on you don't have to pay anything, or you have to choose between a high initial investment and then later on you are free. Okay, so most of you must have experienced a patient like this, where you feel that, oh my God, my artery line, it's not going in at all. You must have come across bariatric patients. So in these patients and in certain other situations, non-invasive monitoring can be a boon. So the other indications for non-invasive hemodynamic monitors could be ambulance transportation of patients and patients posted for minimally invasive surgery like laparoscopic surgery or robotic surgery, patients who have to undergo a renal transplant where you have to preserve the radial artery for formation of a AV fistula for dialysis at a later stage, and in patients with low left ventricular ejection fraction undergoing minor surgery like hysteroscopic DNC or a clot evacuation. So in these patients, for 15 minutes, you would not like to put an invasive arterial line. Here you can use the non-invasive hemodynamic monitors. Then there are certain surgeries which are prolonged and low-risk surgeries like an RALP on neurobot, where, I'm afraid to say you have to cater to the learning curve of the surgeons here. Then there are emergency situations where TEE can be really useful, and so on and so forth. The indications are a lot many. Okay, so but I'd like to tell you that the isopressure curve is really, really important for your patient safety as well as yours, you know. And when the BP of your patient lies on the isopressure curve, you have to ensure that the cardiac output of your patient multiplied by the systemic vascular resistance equals 80 times the difference of mean arterial pressure and the CVP of your patient. Then you can never go wrong. So below this isopressure curve is the hypotension zone, and above this isopressure curve is the hypertension zone, both of which need to be avoided by you. Okay, so this is a clinical diagnosis tree, clinical decision-making tree using certain new devices. And we use the cardiac index here. And subsequently, let's see how to use this clinical decision tree. So there's a 60-year-old lady undergoing cytoreductive surgery for CA ovary. Her initial parameters were cardiac index 1.8, intrathoracic blood volume index 741, extravascular lung water 22 milliliters per kg, and stroke volume variation 25%. So here we notice that the cardiac output is low, intrathoracic blood volume index is low, and the extravascular lung water is high. So as per this clinical decision-making tree, we start fluid loading. So after fluid loading, what happened? The cardiac index increased to 3.66. The intrathoracic blood volume index, it increased to 1399. The extravascular lung water improved to 14, and the stroke volume variation also improved to 15%. So since the cardiac output was high, the intrathoracic blood volume index was high, and the extravascular lung water was also high, we stopped the fluid loading. So, my dear friends, in this particular case, there was flash increase in permeability due to possibly transfusion-related acute lung injury associated with severe hypovolemia, which resulted in spontaneous improvement despite liberal fluid administration. So this was an example of how to use the clinical decision-making tree and use the various parameters provided by advanced hemodynamic monitoring. So now you can see that if you have the HPI available with you, you are rich, and you can use this other simpler algorithm. So whenever your HPI is more than 85% or your mean arterial pressure is less than 65 millimeters of mercury, you should start treatment immediately. You should see if your EA-dyne is low and your systemic vascular resistance is low, or if your stroke volume variation is high. If two or more of these criteria are present, then the most likely cause of hypotension is vasoplegia, and you should start noradrenaline or vasopressin. If that's not the case, and your EA-dyne is high, and your stroke volume variation is high, and your stroke volume is low, so if any two or more of these criteria are present, then the most likely cause is hypovolemia. And in such a situation, you give 250 ml of colloid bolus to your patient over 5 minutes, and the bolus can be repeated after 15 minutes if the situation persists. But in another clinical scenario, when your stroke volume resistance is normal to high and your stroke volume variation is also normal, but yet your stroke volume is low, all three of these are present, then the most likely cause is an impaired cardiac contractility. And in such situations, you should start with the dobutamine infusion or give dopexamine. Right. So now this is a simple algorithm based on stroke volume and stroke volume variation, which you can use in your day-to-day clinical life. So whenever the stroke volume variation of your patient is more than 13%, you give a fluid bolus, 250 ml of colloid over 5 minutes. Now, if there's a 12% increase in stroke volume by this measure, then very good, and you go back to the same. But if there's no increase in stroke volume even after 1 minute of fluid bolus, then you stop giving the IV fluids. Now, if your stroke volume variation is less than 13%, you look at the mean arterial pressure. If that is more than 65 millimeters of mercury, well and good. If it's less than 65 millimeters of mercury, you look at the cardiac index. Now, if your cardiac index is less than 2.2, then you start with an inotrope. And if your cardiac index is more than 2.2, then you begin using a vasopressor. So the colloid which I recommend would be, say anything, stirofundin. You can use Voluvin, or you can even use gelfusin. And balanced crystalloids like stirofundin and plasma light, even ringer lactate can be used if you don't have colloids with you. Inotrope, which is most commonly used, would be dobutamine, and NORAD is the preferred vasopressor. Okay, so now let's begin with the second half of the presentation, which is transesophageal echocardiography. Now, this is not as confusing as it looks, because you should have a knowledge of the anatomy of the heart first. You should know that the right heart structures are present on the anterior aspect of the heart, whereas the left heart structures are present on the posterior aspect. Right ventricular outflow tract arises anteriorly and passes horizontally back, and the left ventricular outflow tract arises posteriorly, moves upwards and anteriorly to the right. From above downwards, the heart valves would be the pulmonary valve, followed by the aortic, then the mitral, and lastly the tricuspid valve. The aortic valve is distinguished by the distinct Mercedes-Benz sign, like the logo of the Mercedes car. And the transesophageal echocardiography probe, which we introduce into the esophagus, is 1 meter in length, and it's very thick, 13 millimeters in diameter, so double the thickness of the normal fiber optic bronchoscope which you use. Okay, so let's see what are the parts of a transesophageal echocardiography probe. The tip has the transducer lens. Then there is the control housing, which comprises a lock lever, a large wheel for anti-flexion and retroflexion, and a smaller wheel for lateral side-to-side flexion. It also has buttons for digital rotation or omniplane rotation. And of course, all these are fitted onto the transducer handle. So very important points while inserting your transesophageal echocardiography probe would be that never ever should the probe be forced into the esophagus. Otherwise, it might result in a perforation or trauma. And one should always keep the probe tip neutral while advancing it. Also, the control wheel should always remain unlocked. And lastly, but not the least, suctioning of gastric air and fluids by using a nasogastric tube goes a long way in giving you an improved image quality. Okay, so now let's study what are the maneuvers or manipulations which are possible with the TEE probe. Now, these would be of two types. Firstly, the physical manipulation. You can advance the TEE probe into the esophagus or you can withdraw it. So there are various depth markings present on the TEE probe. At every 10 centimeters, there's a mark. All right, then you can turn the TEE probe on its axis either to the right or to the left. And you can retroflex it as well as anti-flex it using the larger wheel. And using the smaller wheel, you can flex it from right to left. That is lateral flexion. Then without moving the TEE probe physically, you can still change your images by digital rotation or omniplane or multiplane rotation. So this can be done from 0 to 180 degrees. As you can see on the right-hand side of the image, there is a 4-chamber view of the heart. Now, this is obtained at 0 degree position. Now, when you digitally rotate it to 90 degrees, you get a 2-chamber view of the heart. And now again, when you change it to 180 degrees, you get a view which is a mirror image of your first view at 0 degrees. So 0 degrees and 180 degree views are essentially the same. It's just that the probe is sweeping from right to left in the first case and from left to right in the second case. So they are mirror images of each other. Right becomes left and left becomes right when you change from 0 to 180. Okay, so the important views, the important levels are the upper esophageal view at 20 to 25 centimeters depth, the mid-esophageal view at 30 to 40 centimeters depth, and the lower esophageal view, which you obtain at 40 to 45 centimeters depth, the transgastric view, and the deep transgastric view. All right. So finally, due to paucity of time and because you guys must be really tired with all this teaching, I'll concentrate on just the 5 views which are important for oncoanesthetists. We shall discuss the mid-esophageal 4-chamber view, followed by the mid-esophageal 2-chamber view, the right ventricular inflow-outflow view, the bicaval view, and finally the transgastric short axis mid-papillary view. Right, so let's proceed. So now first is this 4-chamber view. Mid-esophageal 4-chamber view is obtained at a probe depth of 30 to 35 centimeters by keeping the probe in neutral position at a sector depth of 14 centimeters and a multiplane angle of or digital rotation of just 0 to 10 degrees. So its diagnostic utility lies in the fact that it can detect an atrial septal defect, any dilatation or hypertrophy of the cardiac chambers, any regional wall motion abnormality. It can also detect mitral and tricuspid valve disease and any intracardiac error. You would do well to remember that the left atrium forms the apex of the sector. The right atrium lies just below and to the left of the left atrium. The right ventricle appears triangular, whereas the left ventricle appears elliptical. And moreover, the length of the right ventricle is just 70% of the left ventricle in this 4-chamber mid-esophageal 4-chamber view. So now, after electronic rotation by 90 degrees without physically moving the probe, you can get the 2-chamber long axis view, which has the diagnostic utility of having a view of the left atrial appendage, any mass in the left atrium, any thrombus there, left ventricular apex pathology and left ventricular apex systolic dysfunction can be diagnosed by the two-chamber view. And also, the left ventricular ejection fraction can be calculated by this view. So, another view which I'd like to discuss is the inflow-outflow tract view. And here you can see you have to withdraw the probe by 2 to 3 centimeters after getting the 4-chamber view, and then again rotate digital rotation by 60 to 90 degrees. So what you get is that you see that the right atrium, the tricuspid valve, the right ventricle, and the right ventricular outflow tract, as well as the proximal pulmonary artery, they all wrap around the aortic valve. How do you know it's the aortic valve? You see the Mercedes-Benz sign. So all of these wrap around the aortic valve, forming a 270 degrees arc. So in this view, you can diagnose the pulmonary valve, the proximal pulmonary artery, and the right ventricular outflow tract pathologies besides the RV and pulmonary artery size. Orientation of the pulmonary valve is perpendicular to the aortic valve. So the pulmonary valve is seen in the long axis whenever the aortic valve is seen in the short axis, like in this view. Okay, so you can also note pulmonary stenosis here by noting the turbulence beyond the orifice. So it's useful in management of acute intraoperative thromboembolism in renal cell carcinoma patients, and also for confirmation of the pulmonary artery catheter position. So now we come to another important view, or the mid-esophageal bicaval view. Okay, so again, you go back to your home view or the 4-chamber view, and from there you perform electronic rotation to 90 to 110 degrees, and then rotate the probe clockwise to face the right heart. And you have, voila, you have the bicaval view in front of you. And this bicaval view is used for primary diagnosis of atrial septal defects, any atrial myxomas or other tumors. It gives you the point of entry of the superior vena cava for verification of correct CVP line placement. It also gives you the entry point of the inferior vena cava into the right atrium, from where you can gather the fluid volume status from the inferior vena cava diameter. And from this view only, you can calculate the SVC or IVC collapsibility and distensibility indices. So here you can see that the bicaval view of the TAE, you can calculate the SVC collapsibility index, and from the TTE you can calculate the IVC distensibility index. So at our institution we gave goal-directed fluid therapy using these indices in patients with low left ventricular ejection fraction undergoing major cytoreductive surgery with excellent results. So the final view is this transgastric view, the mid-papillary view. So the probe depth is adjusted to visualize the papillary muscles of the mitral valve at the 12 o'clock position. The degree of anteflexion is altered for optimal visualization of the anterolateral papillary muscle. And in hemodynamically unstable patients, the papillary muscles seem to touch each other with every systolic contraction of the left ventricle. So it means that your patient is highly and severely hypovolemic. This is the kissing papillary muscle sign. So left ventricular dilatation, hypertrophy, and systolic dysfunction, along with global and regional wall abnormalities, can best be detected in this view. And this again is the only view in which the myocardium supplied by the left anterior descending left circumflex coronary artery, the right coronary artery, can be seen simultaneously. And it's also useful for assessment of the right ventricular free wall and also the interventricular septum. All right. So pericardial effusion can also be visualized as a distinct echo-free space between the epicardium as well as the pericardium in this view. So this is a really important view. Okay, so finally, I'd like all of you to remember the basic difference between a TEE view and a TTE view. So in transesophageal echocardiography, you see the atria on top and the ventricles below, whereas the heart is inverted in case of TTE interrogation. So there you have the ventricles on top and the atria below. So a TEE is more user-friendly for the anesthetist. So finally, what is the take-home message? I would like all of you to note that no monitoring tool, no matter how accurate by itself, has improved the patient outcome. Effects of hemodynamic monitoring tools on outcomes are only as good as the subsequent protocolized treatment by you, because you are the anesthetist, you are in charge of the case, you are the man or woman behind the wheel, and you should not be caught doping, and you should be well, versed with the various hemodynamic monitors, your tools, and how to use these tools. And also you should note that the cost of disposable sensors and standalone monitors may be counterbalanced by a reduced postoperative morbidity and a reduced length of stay in your patients. So with that, I'd like to thank all of you for a very patient listening. And I'm open to all your questions. Let's proceed with that. Thank you so much.
Thank you, madam, for the very interesting session. You have taken us through the various modalities, the advanced modalities of hemodynamic monitoring for any of the patients who are undergoing major surgical procedures, and definitely the oncosurgical procedures are mainly with the background of impact of the various pre-treatment these patients would have received. One question, interesting question from Dr. Vandana is, though we have many of these newer monitoring tools, but we are usually concerns about the comparison with the gold standards, or in other way, the validity. So, Dr. Shagun, can you think of when you use different modalities or newer modalities, how valid and reliable these tools are in real sense?
See, actually, I would like to go back to the accuracy slide to answer this question of yours. So let me go back to that first, should we?
Yeah, please.
I'll have to share my screen for that. Just a second. Okay. So I do have a slide on the accuracy of the various monitors, where we see that the semi-invasive monitors are more accurate than the non-invasive monitors, but then invasiveness is also has to be taken into account. So the semi-invasive monitors, yeah, here we have the slide. So here you can see that the LIDCO has a percentage error of 35% as compared to the pulmonary artery catheter. The PICO has a higher percentage error of 41%. The flow track has a percentage error of 40%, and the NECOM that of 47%. Similarly, CardioQ has a percentage error of 64.5%. And similarly, ICON more than 40%. And ClearSight, of course, you have better reviews. The percentage error is just 25.15% as per a study by Wong et al. And then you have the TEE, which has better reviews, and moreover, it's non-invasive. And you have a good correlation with the pulmonary artery catheter as well as with stroke volume variation. So nowadays, only for LIDCO, PICO, FlowTrack, and NECOM, you have comparisons with the pulmonary artery catheter available, also for CardioQ. But others, they've compared with each other, like capsthesia with FlowTrack or TEE with stroke volume variation, so on and so forth. So as a thumb rule, of course, semi-invasive monitors are more accurate than non-invasive one, with the exception of transesophageal echocardiography. and capsaicin to a certain extent. Does that answer your question, ma'am?
I think that's clear. Only thing what we need to remember is when we are talking about the various newer tools where we are using a lot of data, we need to understand that the outcome from these newer monitors are based on the various data they have collected from various sources, and they have input those data into the system. And when something new comes to them, they try to compare it. So that's why if you see the older versions of these computers or these monitors, monitoring tools, they had a very limited data, and that's why the accuracy was not so good. But over the time, they have evolved into the newer versions, and they have millions of data that has been incorporated. So the accuracy or the reliability of the measurement by these newer tools has increased now because the data input has been very into a large number that has been put into the system, and that is how they give the values. So in many sense, it gives a better idea of various tools, maybe when we're talking of predicting something or actual at that moment what is happening, and probably the is with it because it is more or less what actually the patient is having.
I would like to add here that there is a regional or geographical difference in accuracy as well, because the data set which has been fed into these devices is basically European or American. So Indian patients and maybe even African patients, the accuracy might differ from what is already given here. And we need to generate more evidence, for our subset of patients to get more accurate results from these advanced hemodynamic monitors. So more studies are required, sir, and you can, be a pioneer in those.
If anybody has any more questions, please write it in the Q&A or the chat. We can discuss with the expert for any query, but I'm sure that we have covered many of the aspects. I think before the question comes up, I will ask Dr. Shagun, when we talk about these tools, they don't require learning curve or the interpretation because they are more of a graphical interpretation can be given based on the values these have.
Yeah, very user-friendly.
Very user-friendly. But when we talk of the transesophageal echocardiography or transthoracic echocardiography, it is, to a certain extent, it's based on the user's experience to interpret.
Very true.
We may not be getting the actual numbers, actual interpretation. We're getting certain images, and those needs to be interpreted on the background of the user's experience. So I would like to ask Dr. Shagun that those who are new to this technology, how much is the learning curve and what is the right way of learning? I will ask for both the things, transesophageal echo and even for transthoracic echo, which sometimes there are newer tools which has been added to even for the other sites like the carotids or the IVCs, which has been used in multiple ways. So how much is the learning curve and which is the best way to learn it?
Sir, actually, that's a very good question because transesophageal echocardiography, you have it all depends upon your experience with the probe. And of course, in India and elsewhere, you require a certification to use it. Not anybody and everybody is allowed to use a TEE. Otherwise, it can result in it has medical legal implications as well. So you can begin with the 5 views which I have taught you today. The mid-esophageal 4-chamber view, the 2-chamber view, the bicaval view, the inflow-outflow tract view, and of course the transgastric mid-papillary view. So these 5 basic views you should become confident in. First and foremost, you should know how to manipulate the probe, how to where to stop, where to rotate, and you should have a 3D image of the heart in your mind so that you can get your images right. And you should know that rotation is possible by the multiplane technique, the digital technique as well. But for all this, you have to have the 3D image of the heart in mind. And yes, it has a steep learning curve, but once you learn it, it becomes an invaluable tool. So if you have it in your OT, first use it outside. See how it gets retroflexed. See how to move the wheel, the larger wheel, the smaller wheel, anteflexion, retroflexion, lateral flexion outside the patient. And then use the same thing inside the patient. That way you'll be more gentle and you will cause less injury to the patient. And of course, you can go ahead with a month-long course or a week-long course training in transesophageal echocardiography. TTE is easier, but then it's not very useful for us because most of the times we need it intraoperatively when maybe the abdomen is open and the chest is draped and painted. So of course, for us, TEE is more useful and we should go in for that and go in for courses which tell us a lot about these.
Perfect. I think we need to start get trained from some expert person, and once we understand its basic learning, and then it will be having a very steep curve, and we can go ahead and do it to identify the various interpretation of various views that we get on, especially the transesophageal echocardiography.
So JROP is one such institution in Delhi where you can get such training.
Okay. So, anybody has any comment? They can just unmute themselves also, I hope. Rituparna, can people unmute themselves to ask questions directly?
Yes, sir, we can unmute, but then the participant has to be promoted to the panelist, sir.
No issues. For a moment, now we can.
Okay.
Yeah. So each one of you can unmute and directly ask the expert.
So I would request the delegates to kindly raise your hands, please, raise hands individually, so that we can trace who all are having queries or want to speak out. Dear delegates, if you are having any queries or any comments to speak out, please raise your hands.
Dr. Shagun, can we stop the screen share if it's okay with you?
Yeah, sure. That's it.
I think session was absolutely great, so that so people does not have much questions, because most of the things were covered very nicely by you, Dr. Shah. And
thank you, sir.
So I don't think there is any question left. So I just want to say a sincere thanks to you, madam, for a wonderful session.
I reciprocate the same, sir.
And thank you all the participants today for coming to and joining the SOPSI webinar. And we assure you that the Society of Onco-Anesthesia and Perioperative Care will continue their e-education series. It was 39th today, and we'll continue with the same series with good topics, with the good speakers in the near future. And we are absolutely on time today as well. It's just 3 minutes crossed. So thank you once again to everybody of you, and thank you, President. Thank you, President Dr. Josna Goswami, Secretary Dr. Sohan Solanki, Treasurer Dr. Anjali Pinde, for all the efforts in bringing such a nice webinars under the panel of SOPSI. Thank you, everybody, and have a good night. Bye. See you.
Thank you once again, doctors, for sharing such valuable insights. Anjali ma'am, closing comments from you.
Thank you so much. Thank you to all the participants, and thank you, Dr. Shah, for this excellent presentation. Good night, everyone.
Thank you. Thank you, everyone, for being with us. I hope you had a seamless experience. So with all your permission, dear doctors, we are signing off for today and looking forward to host you again very soon. Thank you. Thank you, everyone. Good night.
Thanks, and good night.